It's such a pleasure to have so many people with us this morning in Shoreditch House. And thank you for buckling through the rain and the crazy London traffic to be here with us this morning. I'm Francesca Egerman White, and the family will be Charlotte. So we're here this morning to all discuss how we collectively can expect that, as well as really exploring how to navigate your skin, hormones, and also self-identity in preparation for pregnancy and beyond. After all, whether we're planning to conceive, whether we're battling those early stages of pregnancy, or whether we're also struggling to reclaim a sense of self in the aftermath, I'm sure we can all agree that our experience of this chapter will be completely different for each of us. But it's also a time to riddle deep questions. So what can we do to better prepare physically but also emotionally for the road ahead? And who are the people, the products, and the communities that can really help support us as we embrace our next chapter? Now, we'll dive into all of that very shortly, but before we do, a quick bit of information on the Beauty Triangle. When we founded the Beauty Triangle, it was to educate and empower audiences on all aspects of their health and well-being, and always critically from a holistic standpoint, which is why you'll always find 3 amazing experts on our panels, each of whom is an absolute authority in their given area of expertise. But we also want to have the conversations that are going much more unspoken in the industry and in the world of wellness at large. And in doing so, also connect you with the most authoritative voices in those equal spaces. On that note, it gives me great pleasure to be joined by 3 amazing women up here today, starting with consultant dermatologist and skin-to-skin advisor, Professor Caitriona Ryan, also gynecologist and founding obstetric advisor at the 10th, Miss Claire Mellon, and finally a researcher, embryologist, and founder of Avenues Life, Dr. Cristina Hickman. Such a powerhouse of women up here, and I'm delighted to have you all up here on stage with me. Together, we're going to be taking a real deep dive into ways that we can prepare pre- and postnatally, as well as really unpicking things like topical skincare ingredients, how to control pigmentation, the role of egg freezing, IVF, and also really underlining the power of community as we forge ahead. Hopefully all of you will have received a little program on your place settings. You can find information on all of our speakers on there, as well as a referral card. So if you'd like us to connect you anyone that you hear speak this morning, just tick the box next to their name, leave your details, and we'll connect you. We will have time for some audience questions at the end, so please save up anything until then, and we'll do our best to get to you. And finally, there's an amazing goodie bag for all of you, which hopefully you found on the back of your chair, from one of my favourite skincare brands right now, Skin to Skin. They've developed a really efficacious range of skincare that is safe to use at every stage of motherhood and basically for every woman at every chapter of life. And it's incredible because it gives your skin the effect of having slept for 12 hours. When, if like me, you've only slept for 6, it's a real help. So don't leave that behind. I'm going to hand over to our amazing panelists. They're going to say a very quick hello, and I'll get started with the main conversation. So, Caitriona, over to you. Thank you for being here.
Thanks, Francesca. So I am Caitriona Ryan. I am a professor of dermatology in Dublin, Ireland. I have both a big medical and cosmetic dermatology practice. And I've been hugely interested in doing a lot of research in the changes in skin and skin conditions during pregnancy and during the postpartum period as well. So I'm delighted you're doing this and that somebody is, exploring this area, because often I think women are left being told they can't do anything when they're pregnant or breastfeeding, or you're trying to conceive. So glad you do this, Jessica.
It's a scary chapter, but thank you, and I'm excited to hear what you have to tell us on the panel as well, Caitriona. Thank you. Is that how you hear?
Hi, I'm Claire Mellon. I am an obstetrician and gynecologist, although I'm sort of here mostly to talk about the 10th at some point. But I have a large group of doctors now who have a sort of, can basically cover all gynecology aspects, and particularly we do scanning, etc. And it's really just evolved, not just out of necessity, because we felt that we had women who wanted women. And we've just got it's kind of a nice organic growth of a company that can cover everything. But the most important thing about my practice, I think, is that we have this very holistic approach, and I'm obsessed by nutrition. I've done my naturopathic course, and I'm obsessed by sort of exercise and psychology, and so we have sort of we have reflexologists and acupuncturists, and I just think that sort of aspect a whole holistic care is important. But I obviously interface with other doctors, which is the most important thing. But
Absolutely. And I have to say, we're so thrilled that you managed to be with us this morning, because I know that you're always sort of hesitant to commit because you might have to deliver a baby at the last. So.
well, she did phone me to say things are happening, and I said, okay.
Hold on for another hour.
No, she'll be all right. She'll be all right. We've sent her back to bed. Don't worry.
Amazing. Thank you, Claire. And Cristina, thanks for being with us.
So I'm Cristina Hickman, but call me Chris. And my job is to take care of sperm, eggs, and embryos. I've been in this field for 25 years on a mission to make sure that everybody who wants to become a parent can become a parent. The problem is there's so many barriers out there preventing so many people achieving that dream that we're just chiseling out these barriers one at a time. So we have built this clinic, which is now my 13th clinic. Sold all the others because this one's designed to take care of you and make sure that we have 100 specialists at your disposal. Find the right specialist that understands you, and you leave understanding what is your own fertility, because you have all of these technologies that are not in use anywhere else. And this is kind of what we're trying to do: get you to understand your own body, your own fertility, with a doctor who is compassionate and gets not just your medical side, but your spiritual side and your feelings, and treat you as a whole. So that's what Avenues is all about.
Amazing. I'm really excited to dip into that a little bit more and explore the exciting advancements that you're making as well in the world of fertility, Cristina. So we'll kick off with the main conversation. I'm going to start with Professor Caitriona first. She's already introduced herself, but from my perspective, Caitriona is an absolute encyclopedia when it comes to skincare knowledge. There's nothing that this woman doesn't seem to know about how the skin reacts at any stage of motherhood, or indeed menopause or menopause. So you're definitely one that I need on speed dial right now. But maybe you can start by explaining to us some of the common skincare conditions that women are facing as they embrace motherhood, whether that's conception, pregnancy, breastfeeding, or even going through something like IVF.
Yeah, well, that's how good we hear for it.
Sorry, it's a big question. I know, let's break it down.
But you know, we are stop talking. I think that the most common, and actually you see it almost, even accentuating when somebody's going through the IVF journey, especially for hormonal stimulation, is that the change in the hormonal profile, which triggers different things in different people. So for example, in somebody who has psoriasis, eczema, lupus, you often see their skin improving during pregnancy. It was crazy afterwards. But for about 6 weeks after a pregnancy, people have gloss horrendous flares, sometimes need to be hospitalized. But when it comes to normal skin, and what happens to most people when they're pregnant, we certainly see hormonal acne can really take off during pregnancy, particularly in around the second trimester. Again, it's the fluctuations in hormones, particularly progesterone, that will cause sometimes very, very severe cystic acne in people who've never had acne in their whole life.
And that's so difficult because there's a change there's a change going on in every sort of part of your life, in your body, and the last thing you then need is for your skin to be playing up at the same time.
Especially when we have no access to anything because we're pregnant.
Yes.
And we do, unfortunately, we see a lot of women who have dreadful scarring. Because they weren't able to, intervene properly with acne during the pregnancy period. So certainly, I think adult hormonal acne is a huge issue, and it gets worse during pregnancy, and also in the postpartum time too, when you're so stressed and tired, and the last thing you need to be dealing with it is acne as well. Also, your skin becomes more sensitive to things. So there's certain products that you would use in all your life. And then your skin barrier changes. So that's one of the reasons, outside of the potential issues with if your endocrine system, that which help keep away from high concentration essential oils, they actually can trigger pontic dermatitis.
So yeah, it's interesting because we often think that when our skin is misbehaving that we need to go for a sort of gentle, all-natural approach to skincare, don't we? But plants are just as powerful as some of these active ingredients.
That's the worst. Most allergic contact dermatitis is plant oriented, and you've heard me talk about it before. I hate this all natural or organic concept in skincare. I think if anything was organic and truly didn't have preservatives, it would rot on the shelf within days.
And if you want to anywhere near your face.
Yeah, well, you're going to be putting, bacteria, fungi, that sort of thing. So preservatives are really important, and everything is made of chemicals. So this chemical-free, preservative-free type thing drives me crazy. And that just word organic on your skincare, it's just driving up the price of your skincare without adding anything.
That's fascinating. But I think you touched on something as well when you said that we're much more reactive and susceptible to almost the sensitivity. Is that because we're seeing a huge amount of focus right now on the skin barrier and sort of supporting skin barrier? Is that something that we need to be much more vigilant of when we're sort of embracing all these different chapters of motherhood?
Yeah, well, I think every chapter of life, I'm obsessed with skin barrier. And actually, when you have a really healthy skin barrier, your skin is at its best, glowing and radiant. And during pregnancy, absolutely. And, the other period of life, which I'm in, is perimenopause. And again, it almost mimics the pregnant state. So again, you're really trying to strengthen your skin barrier. And that's with very simple degrees, like ceramide, glycerin, Exuin is one of my favorites, and Antuin. So everything you can use to really strengthen your barrier, make it less susceptible to irritants, and give you that lovely glow. As we all talk about the pregnancy glow, but I think most women pregnant are glowing for all the wrong reasons. So it's actually flaring over there, she's flaring. Other big thing I see in pregnancy, and sometimes women can't get a little bit of effort properly, is melasma, is pigmentation.
Pigmentation is huge. And funnily enough, I think I shot myself in the foot because Caitriona and I did a preparatory call ahead of this talk. And I said, with my first pregnancy, I really struggled with pigmentation, but I'm fine this time. And she said, oh, just wait. And funnily enough, the other day I caught sight of some in the bathroom mirror and I said, gosh, she was right, damn it.
Yeah, it doesn't happen until sort of T2 or T3, second trimester, third trimester. And we see it, during any time that we're in, at a high hormonal state. So people on oral contraceptive pill and getting HRT. So hugely important. If the only thing you use when you're pregnant is a tinted zinc containing sunblock, do it. You'll save yourself a fortune.
And why tinted specifically? Just that's an extra barrier?
So tinted means you've got iron oxides, and you have to ensure the right type of tinted iron oxides in your formulation. So they help with physical light. So, people think they're doing great by putting the sunblock on their outside. Like my patients know their sunblock has to go on when they get out of their bed and once the lights go on. So high intensity visible light. So I'm in rooms with no windows, but I have a really strong computer in front of me. I'm on the computer all day long seeing my patients, and then really, really high intensity lights. So anyone who's an indoors worker has to have tint in their sunblock, and let it always be zinc. For a few reasons. First of all, zinc is the best thing when it comes to protecting against the whole spectrum of UV radiation. Also, it doesn't make chemical reactions to your skin. So especially when you sensitive skin, so whether you're rosacea, eczema, or you're pregnant, you're much more likely to get either the irritant or the allergic or acne-borne reactions to chemical sunblocks. And then, not to scare, but it's only the face, but we know that chemical sunblocks are detectable in the blood. One day of full body application, you have, high enough growth coming in the blood. Zinc is the other thing that's been shown to absolutely category safety. Whenever
We use elbows, don't we? So it's...
Yes. Well, also we take it. It's probably in your prenatal hormones that you're taking right now. So we take zinc orally. It's a great mineral for anti-inflammatory, for the inflammatory states. So we'll take it with hair loss and whatnot. So if that's absorbed, it's usually a good thing. So I would say that's the one thing to be really, really good about when you're pregnant.
And yeah, exactly. It's almost like you have to relay the groundwork a lot of the time when you're pregnant to ensure that you're not getting a lot of these side effects or skin sort of flares, even just in the aftermath, if you feel that you've escaped it. You were saying, the skin-to-skin SPF has a tube tint sort of range as well. There's a dark one that actually gives you that nice healthy glow, even if you're feeling sort of slightly dug up.
Yeah. So when Sarah developed it, in Ireland, you don't have as much a diverse ethnic population. Everybody is sort of white versus purple. Like,
Guys literally think the soft tan lawn have a float there. It's
hard to. But Celtic skin, I thought it was only going to be the light tinted that would sell. Like, I swear to God, I don't know how many times we sold out of both of them, but particularly the deep tint, because from the start of it all, because it's partly all of our nurses and obstetricians that are telling the patients to buy it, and then Nikki, my partner, from the day one was doing it. But the deep tint, it's like putting 10 drops on your face. You get this beautiful glow when you use it as your primer for your makeup. And so everyone's now using deep tint.
amazing. And tell us, because I think you touched on sort of ingredients that you want to avoid. Well, what are the other red flags? So we spoke about sort of chemical sunscreens and being vigilant about using those. What are the other ingredients that you would really suggest steering clear of here, whether you are pregnant, breastfeeding? Because it can vary wildly and there's a lot of confusion often.
Okay, so the first I will say, when you're breastfeeding, you can do anything at all. And there's a huge amount of information out there. So from the moment the baby's delivered, you can do whatever you used to do. Now your skin may be more sensitive and hormonal, but looking is off the table when it comes to things being dangerous for breast milk. That's been looked at in great detail because we can look at breast milk and the relative infant dose. I inject Botox when patients are breastfeeding, I do myself.
Really interesting. I didn't think I had any injectable treatments until I had finished breastfeeding sort of after 3 months. So I can get 3 months doing it. It's there counting down the months to get.
I have patients who were like dropping on the way home from the hospital. But when you're pregnant, retinoids are completely off the table. Obviously oral, but also topical. And that's something that often don't know is helping the second baby. So vitamin A is teratogenic. And we don't allow any retinoids during pregnancy. The other thing is salicylic acid hydrolysis. So and actually your skin, the varies and varies. You don't want to be using anything that is irritant like that anyway. So there are alternatives though. One we used to talk about was Mercutio, and actually now there's sort of warning signs over that.
As though, so I remember that being really heralded as a sort of retinol title.
And it was, Sarah has done all the research and she's brilliant chemist. But right now in the EU, there is a question mark over Mercutio because of the chemical family that it's from. So there are brilliant retinol alternatives. Obviously, I'm biased, but I think the skin-to-skin multitasking serum is the best thing you can get because I have formulated.
What does it contain as a sort of retinol substitute?
So astaxanthin is one of the most powerful antioxidants you can use. So it's 1,000 times the potency of vitamin C when it comes to antioxidants.
Yeah,
properties, but also it has collagen building properties as well. So I am all about collagen banking. It's all I talk about. Collagen. So astaxanthin for that, and also peptides. So that the multitasking has peptides in it as well. It's got an azelaic acid derivative. So when somebody has acne or rosacea when they're pregnant, the only topical we can prescribe as dermatologists used to be considered category B. The categories have gone out the window now. But it's azelaic acid. The problem with azelaic acid, especially in Celtic skin, is it can be quite irritating. So make people red. So there's an azelaic acid derivative that is non-irritating in it as well, and then hyaluronic acid and then other barrier intriguing ingredients as well. So that's my go-to.
It sounds like it would be great for the pigmentation that we touched on earlier as well with the azelaic acid. Yes, I've not pronounced that word. And also the astaxanthin, which I also can't pronounce, which you said is just even more powerful as vitamin C.
I think it's a hero ingredient. It's like great to take orally as well, for everyone. So astaxanthin, it's sort of the new sexy one on the block, and it works really well. So yes, that would be your retinol substitute. And actually, I know we're talking about pregnancy, but there are lots of people who don't tolerate retinoids. That is the perfect retinol alternative for everyone, and great for stretch marks as well. Because I've been the answer when you're pregnant. The only thing that actually truly does help stretch marks are retinoids.
I mean, the unready is it all.
Yes, it's like one time that you're trying to prevent yourself, like people talk about bio oil and blah, none of the types. The two things that can help with stretch marks are support wear. So I wore these, the company's gone now, But these things called blinkies that 80 years we held my tummy in place because it's the breakage of elastic fibers and the collagen being on
Like the skin is so elastic and it's gone through so much stretching already at that point that you sort of need to support it and show plane, and you can do a more of a stature as well. But the sort of whole concept of belly banding as well.
let it go again, anybody else your back and whatnot here. That's the one time if you were allowed to use a retinoid that would help. You can't. So astaxanthin and peptides are the best alternative there.
If you need to make it into a bigger size, though, that's my only gripe. Because it's a very small size, and I want to slap it all over my tight stomach at the moment. Yes, please. That would be amazing. Can we touch quickly on hair as well? Because that's obviously a key area of specialism for you as a dermatologist, but it's also a chapter, or rather, it's an area of our body at this chapter that can really sort of come under scrutiny and really suffer.
Yeah, and I think there's very few women who do not have a postpartum teenage influenza. Some of them miss it because they're so stressed and they don't realize that they'll stop their hair. But at the one time that you're already like, feeling like crap and maybe looking like crap as well, and then your hair starts to fall out, it can be, this roll of grace comes back.
Well, you barely have time to wash your hair often after pregnancy, so if let's allow sort of do anything decent with it, so it starts to fall and
So what happens is, teenage effluvium, or people call it the dread shed, is when your hair sheds, and often a copious amount. We're meant to lose 100 hairs a day, but we can lose more than that, and it typically happens 3 months after the insult. So,
because that's the hair cycle, isn't it?
yeah, no, whether the hair cycle is 9 months, and but in the teenage phase, the hair, it happens to the hair at birth, at delivery, but you don't see the shed happen for 3 months later. Sometimes that's delayed with some stress feeding as well. And panic can be really, really terrifying for a woman if she just knows it's going to happen. Good news is it all comes back. Sometimes until the hair cycle is 9 months though. So by the time it's growing again, they're pregnant with the next child. So they feel like they never have helped you up for a while. So what can you do? The big piece is making sure that your nutrients, if you have any nutritional deficiency, it worsens it. So making sure your vitamin D, your zinc, and your iron levels are as good as possible will help mitigate it a little bit. If you're really worried about it from the day where you deliver, you can start using weekends. So topical minoxidil. If you're not breastfeeding, you can use oral minoxidil. They can help. If it's something that really, like there's some women who they almost come to me with midway through the pregnancy and they said they're still traumatized by the last time it happened. Is there anything I could do? And for those women, I'll just institute something like that. I don't want anyone worried about probably the baby physical like that.
Yeah,
Well, you don't have to do anything now. Your hair will start.
And what's the second form of hair loss that we might experience?
So female pattern hair loss is a little bit different, and that happens to it happens to everyone with time. And with some women are much more susceptible to it, especially if there's female or male pattern hair loss in the family. So we all see it with men. So men start to thin and then bald, and it's the exact same process in women, but at a much lower rate. So first your kick hair miniaturizes, and then the follicle involutes, and then once there's no hole there. So once you've got shiny scalp like you see in a man, you can't get it back. And I have patients who come to me as early as 17, 18 with this process already starting. So I start them typically on both spironolactone or oral minoxidil. Once they've finished their family on the two finasteride and dutasteride, that's you deal with the rare of men, and you deal with this too.
And it's safe to take whilst you're trying to conceive. I know anecdotally my husband was taking oral finasteride or minoxidil, and as soon as we were trying to conceive, he had to come off it, and he was like, God, I hope you get pregnant quickly because my hairline, it's already suffering.
And actually, you didn't need to come off it. It's just that if someone is struggling, it can reduce sperm counts. It doesn't have any toxic injury to the embryo that will be raised on.
Yeah, sometimes it's just sort of doing research, isn't it?
So, but yes, once you are pregnant, none of those things are okay. Testosterone I don't allow it in women with childbearing potential. Spironolactone and finasteride are back about that decision within days, so we've got to stop them before they go on to them. Spironolactone can be used in breastfeeding. So it's categorized as safe in breastfeeding, but can't be used during pregnancy. as a risk of testicular feminization.
And you touched on the importance of things like zinc, iron. What are the other supplements that might help us as we sort of change these different stages? And we're maybe conceiving, we're going through pregnancy, we're trying to regain that sense of self. Is there anything that you would really recommend in supplement form to help see us through?
So during pregnancy, you're with prenatal vitamins only, which can't contain vitamin A. That's why they're a bit different. Afterwards, well, I'm obsessed with this now because we're about to launch longevity supplements to help reverse biological age. So the key things when you are not bound to take, I think that's my phone, sorry. I recognize it. I have an arm set for everything qualities. I know all sorts of things about bags now.
Otherwise, it wasn't mine, to be honest.
So my hero, well, there's 32 ingredients in our supplements. I'm not going to get through them all, but omegas are great. So omega-3, nicotinamide, high dose astaxanthin, resveratrol, collagen. So 5 grams of marine collagen a day is just the perfect dose. Creatine, and now we've got more and more evidence that it helps not just in our physical performance, but our cognitive performance. I could go on and on now. All of your vitamins too, and zinc is a really important, zinc, magnesium are really important minerals as well. So, you've talked about being obsessed with nutrition. But the very first thing I should have said is a healthy diet. So protein.
Sometimes say we to forget.
Sorry. So the first thing is to have balanced diet. Protein is huge. And actually, the biggest cause I see right now of hair loss in my clinic outside of the pregnancy thing is Ozempic. And it's not the Ozempic causing it, it is that rapid weight loss. Anyone who has rapid weight loss, their hair will fall out.
Yeah.
So just a balanced diet to begin with, but there are all the supplements that will make a difference if you're
It's another word of warning almost, isn't it? To sort of ensure that when we do come to the other side of having given birth, that we then do, look after ourselves and lose weight in a sort of slow and sustainable way and do feel the pressure to bounce back. I think we're going to talk about this in a bit more. And Caitriona, thank you so much. That was so fascinating. And I loved picking your brains on everything to do with skincare at this really important chapter. So thank you. So our next speaker is Ms. Claire Mellon. She's already introduced herself, but Claire is renowned for her work in gynecology and obstetrics, and she's also championing a very community-focused approach to postpartum care through Wellness Retreat the 10th. Claire, maybe you can just start by telling us about some of the more common gynecological conditions that bring women to your door.
Well, we've got a very large practice that sort of ranges, I think, sort of. I knew this question was coming, so I was just thinking how to answer it. Basically, in ages is the thing. So we have, we can see from 13-year-olds, sort of periods that are very heavy, very difficult, painful, etc. And then it goes through the different ages to do with sort of sexual function. Sometimes we see people with infections or contraception need, and then we go through to fertility wishes when we sort of often refer on to fertility clinics. But we can do a lot of preliminary reassurance if needs be, or at least just assessing whether they need to speed up or not. That's quite a lot of what we do.
Yeah, exactly.
And then obviously we have people then approaching the menopause who have different difficulty with their periods. I mean, periods are, especially in central London, we have a lot of people with fibroids or with endometriosis, or we all have scanning. Well, we have scanning available in all the rooms, and we all scan. And I think a lot of our job is reassurance, actually, if I'm being really honest.
Absolutely.
But it's obviously when we find things, then we would address that depending on an infection or so what do we see? We see a lot of the horrible irritations. We see abnormal smears. Seems to be quite a sort of bread and butter kind of part of our practice.
So it's interesting because you touched on such a long sort of lineage of women who are coming through your doors, and I think so often you hear the word gynecologist, obstetrician, you think I'm only going to see that person when I'm thinking about having a baby or maybe when I've actually conceived, but actually you're such a fundamental part of that woman's journey.
Increasingly,
lifetime.
and increasingly, obviously, this group is far too young, but increasingly the menopause is we have specialists who to deal with the sort of slightly unusual menopause practice of if you've had breast cancer, and then there were people are wanting HRT after breast cancer. So we've got sort of unusual, or urogynecology is the other thing that not talked about enough. But
What's urogynecology?
urogynecology is basically when people have had babies, or perhaps not, but they apparently ketamine use is the big new thing amongst the youngsters now, and they basically become incontinent. So be warned, girls, don't take ketamine.
Wow.
Yeah, ketamine is probably one of the commonest causes of incontinence at the moment, urinary incontinence.
That is fascinating.
And I didn't know, and I went home to my 25-year-old son. I'm like, "Oh my God, have you heard this?" And he went, "Yeah, everybody talks about it." So, sorry to surprise you, but it surprised me anyway.
Who was that? You on these talks? That's fascinating. Yeah. What are the sort of issues that women are facing today when it comes to conception? What are the sort of hormonal concerns, the social concerns? What are the things that are really hampering them in that journey to conception, which might also bring into you?
I think it's going to sound a bit weird to say, but it's a kind of sense of realism. And I don't know how to emphasize it. I spent a lot of time, and we do have a psychologist with us, but it's putting things in perspective, putting it off for just too long, waiting for Mr. Right, all that's fine. And that sometimes now
careers getting in the way.
Careers, but it's not just the careers. It's waiting for everything to be just so I'm having a bonus, I'm doing this. And, we feel that we've got the freedom to choose, but actually, do we? I mean, we can choose. We've got much more control, but we have to be a little bit careful about, being realistic about it. You can't sort of say, "Oh, I'll wait until I'm 45." No. Oh no, I've banked my eggs. No, you have to think a bit realistically about it. And then the other thing is this, that they expect to sort of. I've been trying to get pregnant for 3 months, and I'm like, okay, So
That's probably me.
Well, I think we all once we've decided you want to do it, and I know it's very important, but it's also just I'm as I say, I'm quite into the holistic side, and it goes all the way through from fertility to the end of fertility. But that journey of getting pregnant is getting you ready both emotionally and growing up to sort of realize that you're going to become a parent. It's not just getting a blue line on your pregnancy test. You're actually, as a couple possibly, or perhaps on your own, it doesn't really matter, we're all very open about things, but you are going to become a parent here. It's not just getting a puppy, and so we have to
that's why
think
when
about
they are
these things.
pregnant for 9 months as well, because it sometimes takes that amount of time
to actually realize what's happening.
Yeah, come to terms with it as well. What about the sort of more deep-rooted hormonal conditions, things like polycystic ovaries, endometriosis?
We see
a lot of that.
We do see a lot of it, and partly because we can actually diagnose it much better. We have the imaging techniques that either we find somebody who's found that they've got polycystic ovaries on scan, and then they with Instagram and lots of information, it's much more known about. And do you think I might have this? But there's also a lot of misinformation. So again, it's just trying to put things in perspective. Endometriosis is the classic one. I had somebody whose daughter was having fairly painful periods, and she was convinced she had endometriosis. I mean, you literally physically can't have endometriosis at the age of 12. You can when you're 17, 18, but it's just almost impossible because you just haven't had. But you can have very heavy periods. So again, it's putting things in perspective.
So having the sort of backup of those diagnostics and those scans and those tests and the help imaging, because otherwise, people can find themselves on Google, all their symptoms into ChatGPT and going down a rabbit hole of what they may or may not have. I think sometimes the visibility that you can give women when you do those tests and those diagnostics is really important.
Yeah, and it's much easier as a doctor to be able to say, armed with some results, some blood tests. I mean, there's just bits of the jigsaw, as I call it. You just do some blood tests, take a history, like we would do in anything in medicine. We put it all together and then say, for you, this is where I think you are, and then we give patients of, for instance, they may have a little fibroid or something. They've looked up online about a fibroid and they go, "Oh my God, I can't do this," and I'm going to, and you actually just put it in perspective for them, and there are holistic treatments, or medical treatments, or surgical treatments, and what the realism of all of them are for them. But it's just helping them plan their fertility or plan what might or might not go wrong, but to help people not catastrophize it.
Exactly. And I think sometimes it's having an impartial person, because when you're trying to conceive or you're worried about potentially being able to conceive in the future, it's very hard to see the wood for the trees sometimes. And even your friends and family aren't always the best people to give you advice, whereas
They all have opinions, yes.
absolutely. Whereas I think sometimes to being a carer under the guidance of a professional who really knows their subject matter inside out, that can be incredibly reassuring. We've spoken a lot about sort of planning the conception and the pregnancy, and I think a huge amount is put into that early stage and also the 9 months of pregnancy in itself. But there's not a huge amount of care and attention often given to the aftermath. And I think this is where you and your role at the 10th comes in. Why is it so important that we're all sort of looking beyond the pregnancy?
I mean, it's a very old concept, and then we lost it, and it's now coming back again. I think that's the thing. It's basically on so many different levels, both physically. I mean, it's just on a hormonal level, for instance, and this affects skin, various things. Most people don't realise that when you're postnatal, within 3 or 4 days, you get your baby blues. And the reason why you get your baby blues is your estrogen crashes and you become menopausal. I think I'm probably the only person in the room who's menopausal, but sort of getting there, are you? Getting there. But it's quite a vulnerable time. And you do that on top of having perhaps had a, long labour or a cesarean or some sort of...
That didn't go quite to plan.
Exactly, and all the emotional sort of aspects to it. And no wonder you get the baby blues, and there's a huge change in your body, that sort of matriescence. And we just don't have we don't have the bandwidth we haven't really been programmed to have the bandwidth. We're obsessed by getting the right gear in our house, or but so this is why I'm learning as much as anything, because I'm suddenly realizing as part of the care for my patients. And remember, I've done 35 years of NHS care. So as far as I was concerned, once I only looked after the sick patients, and I only sort of handed the babies back and went goodbye. So I'm learning, since I've been doing private practice in the last 15, 20 years, that you can have a normal delivery. That's a revelation. And you can also, you have this postnatal care part that needs lots more input. I know that families, especially in central London, we have to sort of buy in our family or our village. We just don't really have mums around the corner. Culturally, there are different groups of people that are better at it. I think the Irish are very good, aren't they? They come in and they look after you and they do your messages and they, for cook, etc. But we don't really have that in central London. So that's why I think, the 10th was really interesting to me, because for quite a lot of my patients, it's a curated, it's a well thought through, it's of the sort of the level that you'd want, if that makes sense. Trying to phone up and find the various different aspects, it's quite hard.
I think you're right. We spoke about it just before we came up on station, and you said, in addition to sort of delivering babies and helping women sort of go through that whole journey, you were often previously on hand sort of trying to find good postnatal massages. And I often felt that I was sort of piecing things together myself in the aftermath of my first pregnancy as well, and trying to keep the house going, and trying to make cups of tea for everybody who visited, and doing all of the rest. And it's such an important time to be really investing back in yourself and coming away from that sort of society and all of it, expect just to bounce back and be your sort of vibe yourself straight away and straight on Instagram with you and your new sort of family.
But it's accepting that you need perhaps a little bit of help with food, and you need a little bit of help with some self-care. You need a bit of help with just I mean, as you said, somebody said, having time to wash your hair, I mean, it's those little things, but actually that nurturing, which is done out in East Asia very well, the Chinese, I think in the Middle East, they're doing it quite a lot. Usually you'd have your families and you'd be nurtured and you wouldn't be allowed out the house but we just don't do that. And as I said to you, my husband organised a dinner party for 14 people because he thought that'd be the quickest way to get all your friends around. I'm like,
that's such a male
he doesn't cook. So guess who did it? And my sister found me in tears in the bedroom and goes, oh, for goodness sake, this is ridiculous. But I just had no clue. I just didn't have a clue. And so it's actually just bringing the discussion. I think that's the 10th is brilliant that way, because it's bringing the discussion out front, recognizing that sometimes, perhaps your mother or your mother-in-law are not the people you necessarily want to have around. We've got choices now. And it's lovely if they came and stayed and cooked for you, but it might not be so lovely if you don't have room or
whatever. It might be a bit nicer to sort of have something a bit more impartial.
And the 10th is, you're lucky if you can get to the 10th, but they do the home thing and they can curate different bits for you if you want. And I think that's really where it's going to start talking. And I think what's good is that they're starting with a very high level, and I think it sets the tone for doing it properly.
Yes,
Does that make sense?
agreed.
And I know that sounds like it is a bit of a sell, but I think it is quite a good reason to sort of start it
It's such
high.
a new chapter and it's so unknown and you don't necessarily know how to navigate it. I actually remember having my sister-in-law come over in the first month that I had my son, and she was a professional nanny, and it wasn't until she came over that I actually suddenly knew what to do, and I found a bit of a routine, and I sort of found reassurance in having somebody who I could look to almost give me that I suppose way of life, because everything had changed by that point and it's all fresh and it's all new to you. So I think sort of bringing together in the same way that you've done in your own practice, that sort of diverse, multidisciplinary team of experts who are genuine experts in their own areas. That's really the support that you need, especially when your hormones are raging and you're in tears every 3 seconds and you don't know why.
Well, you don't have time to start, making an appointment for this and an appointment for that. So, but if you know that over a week or 10 days or whatever it is that you can get that kind of looked after for you, and it's of a you don't have to be thinking about it. And actually, the other thing is I do look after a lot of people who don't come from London, so they either from abroad or at the moment I have a lot of footballers that come to London, and well, wives, or actually I look after the football team as well, the Arsenal team, the girls,
Oh, really?
but if they have a baby, they don't they're not there. They're quite young as well, so they don't really know what to do. They've got fantastic families, but they're up in Manchester or Liverpool or Norway or wherever it is, and so they can basically just stay in the tent, for instance, or at home in a hotel or whatever they want to do, but they know that they've got the right people around them.
That's really interesting because there are so many things in the aftermath of pregnancy, breastfeeding being a huge one. We know that your body is naturally equipped to do it. And maybe for you, it's going to be the right thing. Maybe it's not going to be possible. Maybe it's just not something you want to do. But that's a chapter I've seen a lot of friends really struggle with, not being able to breastfeed or struggling. And so I think having the support of lactation consultants, for example.
But there are different types. And the one that I've used for years, I actually encouraged the tenants to start using because she is fantastic. Whereas I've seen breastfeeding consultants, and some of them they're like the police and make you feel guilty if you don't do it, and you've just got to be realistic about what the right. Well, they are, and they can make you feel very low because perhaps you can't do that, or it's just not happening, or whatever. So that's where hopefully it's just having a realism as to what you can offer to the right people.
Agreed. And do you know what I think that's not often touched on when we think about that sort of postnatal chapter as well, as the support of the partner, and how they're feeling in all of this as well, because so often, particularly if you are a mother who's decided to breastfeed, your husband, your partner, whoever it might be, might feel very isolated and unable to sort of come in and support. And I think that's another area that you're sort of really championing as well, making it more of a partnership approach as well. So the woman doesn't just have to feel that she's doing it by herself and that she can find that support from her heart.
Well, we're going to be setting up a new antenatal class because there's antenatal classes out there that don't have partners, and I find that just very weird because all the partners I see, 90% of them are very involved, and I just think actually the more you can get them involved, the better, because they're there and they're keen to help, and postnatally I think I rather hilariously now encourage them to have their reflexology and
my husband will be fully up for that, I tell you.
No, it's fun. But hormonally, I also think that, there's a little bit more knowledge now, and it's maybe a bit controversial, but I've actually started giving people what they call ad-bag therapy for hormones. Okay. So we've had a few patients who...
How's that work?
So if they're really low and just feel sort of menopausal, hot flushes, most women who breastfeed, got one over there, I think, sometimes get hot flushes and sometimes can feel very flat, and it's all psychologically, so you don't go and find another partner and get adventurous, but sometimes over pitches. And so we actually give a tiny bit of, and we give a patch, a 25 milligram patch of estrogen, much like we would do for HRT.
Yes.
The achy joints, the sore vulva, we give estrogen vaginally. But that was never thought about a few years ago, but now we can do that. It won't affect your breastfeeding. People still breastfeed and have periods eventually, once you've got it established, but you can have a small amount of estrogen that just makes you feel as if you're not going to, there's just some people who really crumble,
Exactly, and I think anything that you can take or sort of be supported by to help really elevate you in that very sort of low, or what sometimes feels like a very lonely chapter, can't be underestimated. I think that's a fantastic idea, particularly when you think about postnatal depression and how many women sort of struggle through that silently. I've had friends who've gone through postnatal depression. I didn't think they even realized that they had it almost until they came out on the other side.
Well, it's nutrition, because if you're depleted, that doesn't help. It's hormones, it's companionship. The psychology aspect of things I think is quite important. Some people don't need professional help, but some people do, and it's just having that facility so you've met people, you know who to call, and I think that's the important part. But to talk about it more.
So much so it's really
And of course, urogynecology again, because we all know about pelvic floors after birth.
Well, that was something I was to ask you about, is the sort of aftermath of giving birth and the healing that's required, what we can do at home, what we need to sort of come in clinic to do. What do you sort of advise to the women who you see, whether they've gone through a vaginal birth or a C-section delivery? What are the things they can really be doing to look after their well-being and their repair from home?
I mean, essentially is rest. And don't underestimate that, and you don't bounce back. If you have flu, you'd rest more than you do when you've had a baby. So do listen to it, and if you're tired, guess what? Listen to it. Nutritionally, I do think sort of protein. I think having small meals often, not eating too much sugar, very inflammatory. All the stuff that get your bowels working. So that's why I'm slightly obsessed about it antenatally, because I think it sets up for a good chance that you get things right postnatally. Just during an operation, I mean, if you're having an elective section, make sure you don't have too much sugar before you go in, because guess what? Wind afterwards is one of the worst pains that you can have. And it's just fruit or whatever it is that you might have eaten fermenting, because your bowel goes stagnant. And so, guess what? If you don't have too much of that the day or two before, don't starve, but just don't eat lots of fruit, because then you won't get the gas.
Exactly.
And that just helps you feel a bit better. So it's all these little things that it's just experience that helps you do that. So from a cesarean section point of view, we have, with a colleague, I've got actually a hair product. She's Nicky Clark's girlfriend, and she's or wife now actually. And she does sort of rosemary shampoos for postnatal shampoo things and for restore, etc. But we also have the silicone patch. Just do simple things like that.
I wore one of those, and I think it's an absolute game changer.
Yeah, I think
sort of
totally.
Recovery
It really helps. And then the other thing, as you say, is the support. Good physio, just very simple exercise. It doesn't have to be too much, and that applies to normal vaginal deliveries as well.
I think the pelvic floor is sort of important in both style of delivery, isn't it?
It is.
How do you go about, because so many people find the sort of Kegel exercises and the pelvic floor exercises quite wearisome if they remember to actually do them. Is there any way that we can approach that?
I think keep it simple. They often over egg it, and it doesn't have to be you don't have to have any fancy gadgets or anything. You can get the fancy gadgets, but you don't have them. What you really want to do, and my simplest thing, is just, we're all women, I think, here, apart from one poor man there, but we all know what a tampon feels like. So if you imagine just holding onto a tampon and pretending that you were trying to pull it out, but hold onto it, that's the right action. That's very simple. And do that every time you pick up your toothbrush, which is twice a day, hopefully. Even if you've got a screaming baby, you generally have time to brush your teeth. You might not have time to sit down with an LV and 10 minutes of this, that, the other with a screaming baby, but you certainly have time to brush your teeth. So you just, as you're brushing your teeth, just squeeze 2 or 3 times. And you'd be amazed, if you do that for a month, twice a day, it's more than remembering to do some exercises once a week.
That's fascinating.
So it's just simple and often and forever. That's the best thing to do.
Yes, exactly, that sort of consistency piece.
Yes, exactly. And do it from the very beginning of the pregnancy. If you can. It's just wherever you are, it's just doing that a little bit often that you feel guilty. I haven't done my exercise. I've got to do it for 15, 20 minutes. No, you don't. You need to do it for 1 minute. But you need to do it a lot.
I appreciate you need to just find a way to fit it into your life and your routine, whatever that's looking like at that moment in time.
And forgive yourself as well, because I think in society around the world, postnatally, you're very mollycoddled, apart from in Britain. We're very bad at looking after people.
Why is that? Just that societal norm for some reason?
I think we just lost the family. We would have done it when, 20 years ago, 30 years ago, your mum would have come round and stayed with you, and, we just lost it. We just don't do that. We all have to be perfect and rush around and, But no, I think so. Just be gentle on yourself and allow yourself to have help.
And try and find that support network and that village, whatever that might be. Thank you so much, Ben. Really, really insightful. And I loved sort of hearing about everything that women experience on the journey towards pregnancy and beyond under your supervision. Thank you. Our final speaker is Dr. Cristina Hickman. She's the founder of Avenues, embryologist, researcher. I've actually been into Christina's clinic. It's like a James Bond lair, sort of fertility expertise and know-how, and it's really, really mind-blowing. So really delighted to have you on the panel this morning, Cristina. What stage do you find men and obviously, women and men can come to your door seeking sort of fertility guidance?
So at the moment, they are been trying for a while, and then they come to our door to say, help us, because we've been struggling. Sometimes they've been trying for a little bit too long, and they should have come sooner to us. That's one of the things that we see. Sometimes they come in assuming that it's a woman's issue because we still associate fertility with the female side. Maybe they didn't see a gynecologist. I've been assessing her multiple times. Nobody thought to look at him. That's another very common thing. A lot of the patients we see, they've been trying care elsewhere and just wasn't being successful, and they wanted a different approach. They felt they didn't understand the reason why it wasn't being successful. You need to understand that in this field, we've been trained in my 25 years that it doesn't matter the why. If it doesn't work, just put them through a cycle again. But we've come to the understanding, especially by speaking to patients, the why matters.
So I think so that patients can almost come to terms with something or understand it to be a part of that journey rather than feeling like they're out of control.
Only 30% are going to go home with a baby. That's the reality. The majority of patients doing fertility treatment on a per cycle basis are not taking home a baby. So that 30% that have been home with a baby, fantastic, we're happy. The other 70%, we need to find a way, what is the journey to maximize our chance to get to baby, whether it's more cycles, whether it's donation, whether it is, what is the right journey for you?
Yeah.
And you cannot find that next step, what's the right journey for you, if you don't understand the why the first cycle didn't work. So a lot of patients come to us because they want to understand that why.
Yes.
And what we've been doing that is very different to everywhere else is we have been bringing in a whole bunch of technologies to give you better clarity on that why. For example, you have products in the market that you do a little finger prick test, back comes or your hormonal profile tells you everything's normal, you get reassured, I'm good, I don't need to do anything about it. But your hormonal profile is only part of your fertility story.
Exactly. There's such a big picture that you need to really be unpicking.
Yes, so we also do the finger prick assessments, but then we also add to that an AI-driven 3D assessment of your full pelvic scan. So that we're looking at what's happening with your uterus, what's happening with your ovaries, things that your hormonal tests might have hidden.
Yes, exactly.
Right? And then they go further to the man. So the man right now, they go to the semen analysis in a traditional clinic, and they look at 5 or 6 data points, which come from something called the WHO guidelines. Okay, so they're looking at, is the sperm moving forward or not? And how many of them are moving forward? Are there any sperm at all? What's the number of sperm, right? But these 5 or 6 data points have been designed in a population-based assessment. So 5% of men got conceived, that randomized got conception. That's not the right data to use to decide if you should have ICSI, NUI, or ovulation induction, or what is the right treatment for you, which is how fertility clinics are using to make that assessment. And also, it matters how that sperm is moving forward. So we have dedicated a lot of research looking at subcategorizing moving forward sperm in the right way or in the wrong way, which can only be done with AI. So in a traditional minute, they're looking at the first 200 sperm that are counted in my eyes that I can see. But with the AI, I'm looking at millions of sperm, and I'm looking at the way that's right, or the speed. I know how many times I had from left to right, and millions of sperm, which then gives me a categorization that we would have been told that everything's okay with you, but we now identify an issue.
And that in turn obviously helps the patient, both patients, the partnership coming into this potentially so much more and understanding actually what their concern is and how to move forward.
And not just that, we invite them to be part of the decision. The patient gets an app on their phone, and everything we see, the patient sees. They see their embryos developing live as it's happening.
This is amazing. Seeing your embryo in lifetime on your phone, Manny, that's got to be a first.
Empowering, right? And it means that, I remember putting this presentation when we developed the technology in front of all the lab directors in the country, or the embryologists make a decision on, what do you think of this technology? Who approves it? Who doesn't? 99% of the room said, I do not want this technology in my lab. And when we start asking why, all the answers are like, because the patients are going to call me in the middle of the night.
Because patients forget to sort of invested in always checking it.
No, the concern was it's going to create more work for us having to answer these questions. It's going to, how are we going to manage this? I'm already busy enough in the lab. None of the answers were, this helps the patient better understand their care and to be better connected with their care. Mm-hmm. There wasn't that empathy and understanding of how does this improve the care of the patients. Now, we've been using this technology now for a few years. And I can tell you, I've never had a patient call me at 3 a.m. when my embryo has fragmented, explain to me, no, because we're providing a support to them. They know when the next call is going to be with them.
I think it's actually worse if you don't have that insight. Then they already are constantly calling you and saying, how's it going? Any updates?
Yeah.
How is my embryo? Versus actually being able to check in themselves, that's reassurance. That's knowledge, which is power, as we know.
Why is it that when I order a pizza, I know exactly the time when Manuel is putting the onions on my pizza, but I don't know when my embryo is having fertilized. I don't know when they're progressing. Yeah. I shouldn't know more about my pizza than my embryos.
And you invested a huge amount into the technology, haven't you? And when I came over, you also you showed us how a lot of traditional IVF clinics use this sort of cryogenic canisters. It's all quite reach in. Is that the right embryo? No, put it.
It's so scary.
And Christina's lab has this, what I've described as a futuristic vending machine, which basically you dial in, I guess, the data behind the embryo and whatnot, and it sort of delivers it to you in nanoseconds. It's really light years ahead.
You need to ask, where are my eggs, sperm, and embryos being stored? Okay, and in every clinic in London, except for ours, they're stored in a dewar that is this high, that's been designed to store milk. Okay, and we've been using that for 30 years, and nobody thought to put an effort in to design something, because these are the world's most precious cells. We need something that is safer than something that stores milk, right? So what happens is that it's all handwritten, and they lift this little canister from inside going, there's Marina's embryos. Oh, they're not here. Okay, so they then asking around, have you seen Maria's? I thought the computer said it was in canister number 3. And then they go, oh, look at the board. And there's a board with scribbled going, I moved everything from 3 to 7. Because I'm doing a clean on 3.
It's crazy. This is somebody's future child you're talking about. How to sort of protect, but you've just lost them. You've lost them up.
For 20 years, I was doing that. And it's, every day I'm having heart attacks because I know the patient's waiting for an embryo transfer. And I'm, scavenging around the dewars looking for this patient's embryos, right? That's the reality. Nobody talks about this, but this is what embryologists are going through, So during COVID, since I couldn't travel, I couldn't fly, I couldn't do my consultancy, we redesigned this robot that you saw. It's actually British and Canadian. It's American funded, but it's British and goodness. And we decided that we wanted to design what is the safest way to store. So we opened, there's no looking for Maria's embryos manually. I opened the tank with my eyes. It is very James Bondy. So it reads my iris. So if I'm not the person registered on a computer, I cannot even open the system. So extra protection there. It's then being tracked, not just by my team, but there's a whole team that we call the Overwatch that's tracking every one of these robots around the world. So they're looking at, and then this is why we use AI to try and predict when the machine might have an issue. Because there's so many sensors and there, data-driven decisions to ensure machines are in optimal performance. Yeah. So the chances of something going wrong here are so much smaller than in a dewar that's been designed to store milk.
Well, you're really safeguarding that future fertility as well. I think that's a really important part of the conversation. But when we're looking ahead, and you spoke about, or Claire spoke about, sort of women having frozen their eggs. What's the advice that you would give to women who are not ready to conceive, but they know it's in their future? What advice would you give them around egg freezing?
So number 1, understand your personal fertility potential. This is really important because, so my stories, I had my kids when I was in my early 20s because I knew, because I had a gynecologist, I'm in Brazil, I got private care and I got access to my gynecologist from the puberty and the snoop that I was going through very early on. That's not the reality.
You have that little bit drilled into you from a very young age, or sadly, okay, we're often not getting the hassle.
That was number one on this planning fertility. So my plan was to have children in my mid-30s. I changed that plan. That changes me looking for my partner. That changes me getting married early. That changes. I had my first baby during my PhD. Not the ideal time, but that was the right plan for me. And I only knew that because I did the tests, right?
Because you have that visibility.
I had that visibility. I want everybody to have that visibility. And you need to be having that visibility, not from when you're trying to conceive, from puberty. Understand what's going on in your body very early.
So actually the lesson is to get into much earlier stage.
Exactly. And continue understanding it to menopause and beyond, and understand your reproductive health, right? So this is, for me, is irrespective of whether you want a baby, don't want a baby, just do the tests and understand your fertility. But don't just do a hormone test. Do the full assessments. You got to do your pelvic scan. You got to do your hormone profile. And if you have a partner, you got to look at the sperm.
I was about to say, and would you apply that same logic to the man as well? Is it also to look down to the man from an earlier stage as well? Has to be looking into his sperm quality.
And I know this is unfair, but we have a lot more opportunities of intervention with the man than we do with the women. Okay, because the man is producing the sperm every 80 days is a new batch of sperm, so we can change what's happening in that quality. We had our eggs when we were a fetus inside our mother's belly. Okay, the eggs were there, and we're just reducing the number of eggs as we're going through life. In some very dramatic moments, we get dramatic drops, but it's not waiting to get to your mid-30s. So my sister did the same tests, and she had her kids in mid-30s, planned it, right? So the two of us, we came from the same household, and we made our plans differently according to that knowledge. So understand your fertility, your reproductive potential, irrespective of whether you want children or not, because that will change your plans. That's better than doing that game that we do of maybe that's only my generation. How many kids do you want? You know. So change that game into doing a test. Once you understand your reproductive potential, put together what is your plan, what is your dream, what do you want in your life, reproductive wise, right? And then plan accordingly for that. So what has changed in the last 20 years of my career is that women have more choices now than they had 20 years ago. 20 years ago, our ability to freeze eggs and have them survive and give them to a baby was lower than if you were to have fresh eggs. Dramatically lower. Today, in our clinic, the way that we're doing in our clinic, it's the same success rate. Now, if you freeze your eggs, does that mean you're guaranteed to have a baby in the future? No. But you're playing with the odds and you're improving that. You're not leaving it to chance. You're not leaving it to destiny. You're taking control of it. Right? So it's all about, these are my odds. This is mine. It doesn't matter what is your best friends, your sisters. Or, you were dealt this pack of cards. That with this pack of cards, I'm going to figure out how I'm going to maximize my chance of achieving my dream. She has another dream. This is my dream. So knowledge is important, but not just general knowledge, your personal knowledge.
Knowledge of your own body and actually making that plan. And I love how all three of you have actually so drawn on the idea of making a plan. One of my favorite phrases is have a plan that be prepared to flex. And it's seen me through one pregnancy and hopefully a second one. As much as it might feel sort of OCD to all of us, I think we need to have a little bit of a plan from time to time, even just so that we have greater visibility on what the future might hold. Cristina, I'd love to know a little bit about how you're making the world of fertility a more inclusive place as well. You said that you want to make fertility accessible to everybody. How are you going about doing that?
Oh, so many different angles. So one of them is the education of trying to get people to understand better the fertility. So we've covered that. The second one is looking at who is not having access to care. Okay, so first category of that would be you can't afford care. Unfortunately, in this country, where you live will determine whether you're going to get IVF care paid by the NHS or not. That's unfair. That's wrong. No other country has that, where the neighborhood determines. It's crazy. They have rules based on, the country itself, but nobody has done it based on your address. Okay, that's gotta change. And the last health minister that was going to make that change was Hancock. Unfortunately, a whole bunch of things happened with him. And no other health minister has taken this on to change that inequality. Okay. The second one, so if the NHS is not going to provide you that care, how am I going to afford it? These are treatments that can cost tens of thousands of pounds. So tens of thousands of pounds is unrealistic for the vast majority of our British population. So how are we going to reduce the care? So we have gone out of our way to design a care to what would benefit the vast majority of people who are needing care. How can we make it as cost-effective as possible? But it's not about low-cost care, that's cheap. We're not going to compromise on the experience you're getting, on the quality of the medicine that you're getting. So what we've done is we identified a group of patients that don't need a lot of what our field calls add-ons. Okay, so they don't need those expensive interventions like genetic assessment of their embryos. It's really expensive. They don't need to have something called embryo glue, which is expensive. So we're going to curate the perfect care that's going to maximize your chance. But this only works if you fit a certain criteria. You need to be under 35. You need to have a BMI under 35 as well. You need to have, so we identify a group of patients that we don't need all this extra care that's required for other groups of patients. Okay.
And you're seeing a lot of patients who do come in under 35?
Yes.
You are. That's interesting.
So for this group of patients, with the medication that we've identified, with the attention to detail that they need, is 2949. Including your medication, including your consultation, including everything. There's many other clinics who advertise similar prices, but you go to them, they then charge an extra £1,000 for XC, and in the end you end up paying £9,000. Okay, so this is the actual true care of what they pay, 2949, and this will actually resolve more than half the infertility cases. Now, the first patient that came through to us, the jacket she was wearing was worth more than 2949. Okay,
it's only what people will spend money on.
Yes, but for her it was important of where her money goes. So the second group of patients, and she's pregnant, very happy, on waiting out for the labor. The second group of patients, she was a cleaner, he's an Uber driver, right? So between the two of them, the 2949 is all they could afford. So now we work with them, pay that in 12 installments.
I think it's just opening up sort of accessibility to a lot which can otherwise seem very far away to a lot of women.
Now, if you are a patient over 35, BMI over 35, you're going to need a different type of care. If you're a patient who you're in your 40s, that 2949 package is not the right route for you, because that is giving you this one shot on patients who have a good 70% chance.
Whereas we need a little bit more support. So I need to say,
for these patients, the cost of the care is 18,949. It's a lot more, but that's because we're throwing in genetic testing. We're throwing in 3 cycles, and we don't want them to think on a per cycle basis. This is a group of patients where we need to curate a different strategy. The young patients that qualify for fair IVF, they have a lot of eggs. For this group of patients, we're lucky to get 1 egg on a cycle. So now we need a strategy of how we get you into multiple cycles to maximize the number. Remember, different patients, different journeys. But the equivalent of this package that we're charging about $19,000 in the US is $84,000.
My goodness.
So we have now reduced the cost to baby in this 2 group of patients, unique to their circumstances. The third group of patients that we have are high BMI patients. So these are BMI over 35.
Which is very difficult from a fertility perspective, because these people are really denied care.
They are completely denied care in this country. If you have in private and in public care, they're completely denied care in the vast majority of clinics. Okay, so why? Because the NICE guidelines, are these guidelines that this group of doctors have put together in this country. And then all the doctors follow it, and the NHS uses that to determine who gets NHS funding or not. They have put a statement saying you have a lower chance of conceiving. You must inform the patients that you have a lower chance of conceiving. You also have higher risks during the obstetrics care, which is your specialty, and you need to be informed of these higher risks. That was all they said. The interpretation from the NHS, you don't get care. The interpretation from the other clinics, you don't hear, right?
Now, it's too difficult sometimes.
So we decided to do our homework. Let's actually look at other countries. What are their cutoffs? Now, many of them follow the British system, and they will quote for NICE guidelines. But then we look at the US. If we had a cutoff of 30 to 35 in the US, that's a big proportion of the population.
Well, what is their cutoff?
They don't have
They don't look one at all.
They have discussions on looking at the patients on their health specifically. So what we found was in the SARCS guideline, and the SARCS database, 3,000 patients Because the BMI over 50, not 30 to 35. 22% like birth rates, nobody died. Still birth rates, yes, they were higher than in a group with a BMI that was lower, but doesn't justify denial of care. Yeah, right.
Exactly.
So we now started this whole campaign of, yes, this group of patients carry a lot of increased risk, but it's things like increased risks that are maybe 13 out of 100,000 in the population, they double to 26, or they triple to 36 per 100,000. 0.0000%, right?
Yeah.
So this is something that for us, yes, it requires a more customized obstetric support. Yes, it requires a more customized fertility care, but I do not agree that it's rejection of care.
And I think that's such an amazing line to take. And actually, I even saw you have sort of beds that are sort of so much wider than you necessarily see in a clinic. And it's almost like every detail of the clinic has been designed to welcome everybody.
So what happens with these patients? This group of patients will go to see a doctor. First thing the doctor says is lose weight. Now, I've spoken to these patients because we've thrown events. We have more than 120 patients a couple of weeks ago that came over. Yes. And I heard from them.
Because some of them have maybe, I guess, sort of hormonally related conditions where they're struggling to lose the weight.
PCOS is causing them to be overweight. And in one, like, it's hard to contain your own tears when you're hearing these stories because this one lady, she's like, "Look, Cristina, I was told by the fertility doctor they will treat me if I lose weight. I've been trying now for 3 years to lose weight. And every day I stand on that balance and I don't see the weight coming off."
That's so disturbing.
This then has redefined my confidence as a woman, not just in a woman trying to become a mother, but in my ability to work, in my ability to look in the mirror, but now I am a BMI 29, to give you an idea, okay? This is my BMI 29. I am comfortable with how I look. I don't want to lose weight. I'm not a supermodel. That's not my job. This is how I want to look. And many of these patients are coming in and they don't want to lose weight. And when the doctors are coming, you have to lose weight or I won't treat you. It's not really listening to what the patient wants. And the needs of the doctor are not above the needs of the patient.
And whether anybody has the authority to say you can or can't become a mother.
No.
I mean, that's down to the individual.
But the doctor has a role to make sure that patient understands their risks. The doctor needs to explain very thoroughly, look, these are the challenges that you're going to experience that a patient with a lower BMI is not going to get. So we have put together a package, which for this group of patients is 4949. And in there, we include counseling support throughout the care. So we partnered with Pat's Fertility, who is follow her on Instagram. Her name is Nicola. She's absolutely amazing woman who's trying to support women of high BMI trying to conceive, right? So she provides this mental support throughout the care to the patient. Because again, for this group of patients, it's not just about the medicine. We need to look in a more holistic way. We need to think in terms of how we can help this patient relax. How can we get them to gain more confidence where that is lacking?
Yeah, I think the steps that you need to take to work with that patient and also sort of define what the most bespoke care and support for them looks like. And I think that's something that each of you have touched on, the importance of bespoke care for whichever woman or sort of partnership comes through your door as well. We have to treat everyone as individuals. And I like to say what I loved about all of your approaches is how rooted in science and sort of practical solutions they are, whilst still, I think, really taking on board the self-esteem, self-identity, that loss of control is something that so many women are experiencing in these various chapters of motherhood. It's been such a pleasure to have you all speak on the panel. A very, very big thank you. There will be time for questions. If anybody has any, please do put up your hand if you would like to ask anything of our amazing panelists. But otherwise, all that is left for me to say is a big thank you to everyone for joining us. It's been amazing to have you here. I hope you found it really helpful and engaging. I really have. It's been an incredible opportunity to learn so much about this very untapped sort of area of wellness, particularly fertility, community care, postpartum, prepartum sort of skin hair support. And we'd love to see you back at more events. So please do join us. We've got events happening every month. We've just launched our Beauty Charitable Festival announcement. So that will be taking place on the 25th of January. It's a full day immersion. There's more information on the back of your program. So we'd love to have you there. And we've just released more VIP tickets, which did sell out last month. So don't be too late on those. A big thank you to Sohu House for having us, and also a final big thank you to our amazing Beauty Triangle for all of your amazing insights and wisdom and support. You've been phenomenal. Are there any questions from anyone in the audience? And if not, I'm sure our ladies, there's one at the back for Victoria. Otherwise, I think all of our ladies will be here afterwards if you want to grab them for a quick few moments.
Thank you so much. That's fascinating. As someone who works at the Beauty Triangle hears a lot about this, it's so beautiful to hear you all speaking together. I'm curious to know, because at my age and my part of the journey, which is a lot of the people that we speak to, we have this idea of testing on AMH, and I think it's fascinating about what you said about getting answers, but then comparing your answers to other people. And the AMH scale of what is normal is so broad. How do we determine when we hear that our number is 1 and someone else's number is so different, but we're both normal? Or
Yeah, it's a great comparison, isn't it?
So one thing which the misconception is that EMH is a fixed number and it's not going to change. Okay, so that's not true. So actually the AMH is being secreted by eggs that are inside you of a certain stage of maturity. Okay, so once they go beyond that stage of maturity, which is happening during stimulation, they lose the ability of secreting the AMH and so on. So there's certain things that you can enhance your AMH, and this is where the healthy lifestyle and all of that, should be thrown into it. So understanding your AMH is important, but also get rid of that misconception that it's completely out of your control. Number 2, it's not the bigger the number, the better it is. In fact, if your number is really high, that might be pointing to the fact that you might be PCOS, and you might actually need to have a look at. So the AMH is really a really good measure of your general health. And it's really useful for the doctor to determine what is the dose that they're going to need to give you if you were to go through stimulation. But by itself is not the right measure to say, I am going to have a baby on my own or not. You need it within the context of your androgen follicle count, which you're going to get through your scan, and looking at every other aspect in your body, which can also be seen visually. I would say that the ultrasound is giving you better fertility predictors than the AMH on its own. Now, AMH and age rank very highly in terms of prediction. BMI also very highly in terms of prediction. But all of them together is what's going to give you the highest efficacy of prediction of what's going on with your body. Okay, so don't use the AMH as a single number. Don't use the BMI as a single number. You're not a single number. You're actually a combination picture that we can then define what is the right route for you. So whether you have endometriosis, whether you have PCOS, whether you have adenomyosis, whatever your story is, these tests are going to help us identify what's going on with your body.
I love that approach as well, not just seeing yourself as a single number, because otherwise I think to Vic's point you can feel so low and so subjugated when you hear that another friend sort of levels are something and yours are something else, and I think it's really important to sort of keep in mind the bigger picture about what fertility looks like and all of the various things that can be contributing to that. Are there any other questions? So do the friend Hania.
As GP, I quite often get asked by patients that thinking about losing her eggs. And they say, when is the ultimate time and they shouldn't do that? Obviously, we said it, at least get ripped. But would you be advising they ask them?
So when you're looking generally, I really like individualized care and looking at them, but you need to have the general numbers as well. Your fertility is going to slump, from 37 onwards. Okay, so you need to look at the individual story, because if the patient is already 38, come out, right? If you don't want to have, if you're a footballer and you're a footballer at 38, which might be quite good. But if you're an athlete and you're in your mid 30s, freeze them now. Okay, and I love the fact that tennis, for instance, made that you won't drop in rankings if you're going through egg freezing cycles. And we need to have more of that, especially amongst women who are in jobs where they can't be carrying a pregnancy early on. Second thing is, we should, as GP, be telling them egg freezing great, but plan A should be actually try to conceive early. If that is not an option, egg freezing is a plan B, not the plan A. And then you should be doing as early as possible, but not before your 20s. Being too young is also a problem. Okay, so your fertility goes up in your 18, 19, 20, and then it stays high, and then it drops like a like a waterfall, like a slide at 37. And then once you get to 40, we still do egg freezing because it's circumcised the woman, but we're the first ones to tell them this is not the ideal time. Okay, so as early as possible after your 20s, and don't let it get past the 37. But my worry is that when I give that advice, the patient's going to be waiting until 37. No. Come now, understand your fertility, run your hormones. And my sister is a GP, and we keep comparing what are the guidelines telling you at the moment. And it wasn't too long ago they were still saying to run your progesterone when you're, I don't know. There's a different profile now that we're looking at to better understand. So definitely refer to get the right profile of hormones. Don't do the hormones on their own, do the ultrasound as well. And as early as possible to do the assessment, so we can then discuss with the patients, this is the time to have your egg freezing for you. Okay? But in terms of as early as possible, not before your 20s, before 37, that's the window.
And can I throw that question over to you as well? So at what age would you suggest that women start seeking awareness around what's going on with their intimate health as well? When would you advise women to start coming to see somebody like yourself?
Oh, a gynecologist. Well, I get asked this by moms quite a lot. My daughter is, and particularly my American clients, or sort of West London, they've been having a gynecology visit from the age of 16 onwards. I actually try and unmedicalise it. I know that sounds a bit controversial because there's several aspects. One of them is that you want to have access, and you want to make it not scary coming to a gynecologist, but you also don't need to be prodded and poked and medicalised as well. So I spend a lot of time, trying to say to the mums, your daughter's probably normal, etc., etc. So in short, when do you have a smear? Well, we start smears at 25, which is controversial in America because they should be starting at 18 or whenever they become sexually active. But actually, we know that everybody at the age of 18, if they're sexually active, will have an HPV positive. Not everybody, but most people will. And actually, you're just going to treat people that don't need treating. And so we start at 25 because by that stage, most of the sort of HPVs that you can encounter will have settled, if that makes sense. And so you let the natural course. It's like having a toddler who's got a runny nose. Well, I mean, they get them 10 times a year. That's not a problem. But if you were 30 and had a runny nose 10 times a year, you got a problem. So it's kind of just putting it, again, it's in perspective. We see them for things like, can't get a tampon in or reassurance. It's a lot of neuro work. We have sort of people who talk about sex. Actually, I've got a sexologist who's wonderful. I think I can't remember. We did talk at 180.
That's amazing.
She's phenomenal. Look her up. She's fantastic. But she, it's a lot of it's reassurance, and it's stuff that we probably would not have had access to. And I, wished at the age of 18 I'd known that going to a doctor was more than just, having a male doctor stick a finger in you or put a speculum in you, which is just awful, Whereas now it's very much more gentle and it's kind of talking. And so I say, look, there's your ovaries and they all look great. And it's lovely to see your ovaries on a screen and sort of go, I'm normal,
Yeah, exactly.
So as I say, for that reason, as I say, most of the time it's for reassurance. Yeah. And then they've heard about endometriosis and they've heard about PCO and you say, no, you've got polyfollicular ovaries. It's just lots of eggs. We don't know whether you've got PCO yet. And I do my little chat about sexual care, making sure that they don't get infections with it. They're all pretty good, these kids nowadays, actually. They're sort of,
very clued up. But I
they're
like
not
the
clued
idea
up
of-
about contraception, though.
Oh.
They're not clued up
Not
about
everybody.
contraception still, And then the other thing is you can. It's an opportunity to talk about forward thinking, and an opportunity to talk about talk it as a positive. If you found out you've got polycystic ovaries, well, look, lucky you, because you're not going to wait a year for you not getting pregnant. As soon as you want to get pregnant, go and get checked out a bit quicker because you do probably have polycystic ovaries and you will get pregnant. You just might need a bit of a push in the right direction.
Exactly.
And think about your diet beforehand and, all these sort of things.
And that conversation in itself is helpful.
Yeah. And it's just having access, isn't it? Knowing who to contact if there's a problem.
Yeah.
And as I say, at what stage do you go, what I call the big guns, the people who really do need to go a bit faster and a bit. But so, it's lots of dinner party chats at the age of 25, 27, 28. They all talk about, when you'll get your eggs frozen, etc., etc.
Exactly.
And
How great that they're asking those questions.
yeah,
And a young
but it
age
is
as well.
good. It is good. I offered my 21-year-old niece egg freezing. It was slightly a joke, but it wasn't really, actually, to be honest. Her mum was appalled.
But if nothing else, it probably opens up the conversation.
Open the conversation up, exactly.
That probably wasn't going to exist there before. That's so interesting. Caitriona, I want to just throw the question over to you finally about sort of what age, because there's so much confusion about when we should actually even start using topical skincare. And I know we're here to sort of talk about pregnancy and sort of conception and whatnot. But at what age do we really need to even be using these topical ingredients?
At 0, I would say. Yeah. And I'm talking about sunblock, so I'm a sunblock, like
Sunblock for sure.
Oh yeah. So actually, most of your damage when it comes to skin cancer risk or aging, like the extrinsic aging, is done before the age of 18. You know, we will get greater at our skincare when we start to worry about wrinkles, but actually look after your children. You know, if you can, my kids put on, and they're 6 and 4, they put on their sun cream every morning. It's part of the brushing the teeth thing. So if you can start at 0, absolutely. But when it comes to collagen loss, we don't start to lose collagen until we're 25. So there is no need outside of, if you have athlete, there's no need to be doing retinoids until that point. And then absolutely, like, there's no patient who leaves my clinic without a tinted sunblock and a retinoid at night time. And everyone, if they use the right one or a retinol alternative, something that's going to build collagen. These we're losing 1% of our collagen content from the age of 25 on. And then at that 5 years of perimenopause, 30% collagen content of your skin is lost over 5 years. That's huge. So that's the big status change. So and that's where the oral collagen comes in as well. And then we've got sort of analysis and data that shows the improvement we get with oral collagen too. So from 25 on is the absolute question I think you're asking. Sorry, it's another one.
Is that you're a bit saying that's the menopause toy cadence everything
nowadays. But yeah, so 25.
Okay, interesting. But again, really interesting the point on education and just getting children sort of using things from a younger age, having these conversations at a younger age and thinking about those things from a younger age for their future. Thank you so much, ladies. And if there are any more questions for our amazing panelists, I'm sure you can wrap them afterwards. But a big thank you to everyone for coming today. It's been amazing to have you here with us at Shoreditch House, and we hope to see you again. Thank you again to Bobby T. Chandler.
Great, thank you.